Kenji, because that's why they got a wide QRS, got conductive disease down in the ventricle. But this person, this is a 2 to 1, but this is just a classic Winkie volume. So you got the progressive PR prolongation and drop of beat. Okay. All right. This is Dr. Bag for $100. What is this?
Go back to the ER and do a rectal.
Everybody finished? So you, I mean, what's happened to the P waves?
E-wave is okay.
I mean, the morphology is different.
There is a P wave before every QRS, but when we don't see a QRS, there is no P wave either. So
Okay, so if I was looking at this, what I would do would be to I'd get out the magic calipers, okay? And then I would see if there's a relationship between the P waves. So let's just look at the, well, this isn't long enough.
Say, don't write on.
So I'm not gonna write on there, I will just try to, okay, let's try it like this. Let's try this. All right, so if we're looking at the PP interval, okay, we got a P wave there, P wave there, and then we come over here, and look, you see the way the
They
P
line up.
it's a
match up,
They match up.
see there? So this is somebody that's got, it's not an uncommon rhythm, but what would it be?
Third.
So they got something that's,
It's a genital rhythm.
well, they got something blocking the exit of the P wave from the sinus node,
Yeah.
because it's this sinus node exit block. So, and it's just, so, you know, what I would be thinking when I first saw that would be, is there a PAC in there? So you've got, you know, whatever calls a block PAC, okay? If that's the case, then this wouldn't be back in time, like I just showed you it was. So this is somebody that's, whatever reason, that the sinus node is still firing just like it should, but that impulse didn't get down. So the sinus node exit block.
So what is
What do we do?
treatment? What do we
You
do?
wouldn't do it unless they had, I mean, this would be somebody likely old, kind of sick sinus syndrome kind of person. So, I mean, if they're hitting the deck or whatever, they're gonna need a pacemaker. But if they just have this every now and then and they're not having symptoms, you wouldn't do anything.
But this is not third degree.
No, this is purely a sinus problem. And the reason you get out your calipers or your paper and you saw that it went back in time, so you know it's, whatever it is keeping that impulse from getting out to the rest of the atrium. All right. So what is this? What's this?
Third degree? Say block.
Yeah, it looks like
No,
third
it's
degree.
not third degree.
Third degree, why would you say that?
No, not third degree.
Why not?
Second degree, type 2.
Yeah, I think I put this in there just because this is the example of the, you know, he says, is it 1 or 2? Because it's just a 2 to 1 block every now and then. And so, you know, the important thing is where's the block? And the reason that's important is because people that have Mobitz 2 are at risk of sudden complete heart block, sudden death.
Purkinje fibers.
But this is, do what now?
The block is in the Purkinje fiber.
Right, it's further down the ventricle. This is narrow QRS, so there's probably nothing to worry. It's probably Mobitz 1. I mean, I don't think you say 100%. That's probably what it is.
Mobitz
One.
2.
One or two?
Mobitz 1.
Which type one?
Because the QRS is narrow.
But
But
it's
it's
not-
ours.
no.
Right, but it was just a 2 to 1 block, see? So you can't, I mean, you
Can't
can
really
have,
tell
the
how
moment's
much-
periodicity may be 2-to-1, 3-to-1. I mean, if you have flutter, you may have somebody 10-to-1, or you may have some with moments 1, and it takes 15 beats before they drop a beat. Unless you're really careful, you can't tell about the PR prolongation. So if it's 2-to-1, obviously, you just gotta decide from other things. But the point I'm trying to make is just, where is the block, and what does that mean in terms of the, right, the risk to the patient? All right, now, I got called to see this patient because of runs of VT, and the patient was ambulating, not having any symptoms. So anyway, I just looked at the rhythm strips, that was one, and then can we move that? And that was another rhythm strip. Now, some of y'all might have seen this, but don't answer, but this was another, so let's see what is this? Looks like they're having some ectopy. So then, and so, and I'm like, what is going on here? This one they called the hospitalist, and the hospitalist didn't just call it, said to consult the cardiologist. So what's going on? So is the patient VT? Well, it might be. Wide complex rate a little over 100. Well, again, you can't say VT or not VT whether the patient's walking around or not. It doesn't have anything to do with it. But I just had my suspicion that it wasn't VT, just the situation, patient walking around. So anyway, this is in the EKG look normal, pretty normal. So, wait a minute, I think we got a different patient. Is there, can we scroll? Yeah, I think there's one, go that way, other way. Go the other, up, go the other way.
Oh,
No, no,
no.
the other
Down,
way.
yeah.
Well, something got mixed up. Okay, stop. Okay, so anyway, that would, go back up to the one right above that. So I guess that was I told them let's do an EKG on the patient, and then go back to the one that we just, down here, go up. Go the other way. All right, so, and then that's the EKG. All right, so what's this rhythm? I mean, what are these, what is that? Yeah, so what I did, just to prove it, to try to teach the people something, I said, all right, put the lady to bed, and then what did I do? I went over to the pacemaker and just started doing that. So most of them have that little piezoelectric thing, sensor that senses movement. That's the way the rate response works. So basically, I just did that until she was completely V-paced, and that was her VT. She was just V-paced. I mean, that's, so just on that rhythm strip, probably was the pacer spike was, electricity was isoelectric, so you didn't see the pacing spike, but anyway, the lady was paced, so it's clear that she's paced there. So there wasn't anything to do. There wasn't anything wrong. She was just appropriately pacing when she was walking around. And then when she was, lying down, when she stopped vibrating, then her pacing rate dropped and her sinus mechanism took over. So that's the way I proved it, just beat on a pacemaker a little bit. All right. What's going on in this tracing? Vanessa, you look like you're an everyday thing, nothing you don't see every day. So what's the rhythm over here?
That looks
Right, it looks what?
more
It looks regular, right?
regular, but then
Right,
when you get
but
over to the
what,
right-
what's that?
Well, earlier.
Now, what is that little thing before every beat?
Spikes.
Right, so, right, and then what would you say, if you just saw this, what would you say? Right, so you say the patient's in what? Underlying what? A fib. And so, I mean, this is a VDI pacemaker. You know, ventricular demand pacemaker. So they're paced and then their atrial rate happens, I mean, they're be faster than the pacing rate, so you don't see the pacing spikes. And then, bingo, they start pacing again. So nothing fancy, it's just the pacemaker doing what it's supposed to do. Okay.
Wasn't that sinus arrhythmia because the patient was being?
Go back, I don't, let me go back to this.
That would be the low.
I don't, let's see. I don't think so. I think that's just an artifact where it looks like a P wave right there. I don't really see P waves. So, okay. All right, can we turn this one? Okay.
That is still upside.
It's upside down.
Okay, so I got called to see this patient because of atrial flutter. So what was my conclusion? Adrian? Yeah, artifact. Okay, I mean, you flutter, you'd have to be like a superhero to have an atrial rate that fast. You know, be 800. So that's, okay. But then, so that's clearly sinus. But then this rhythm strip was, what's going on in that rhythm strip?
Depression.
Upside down, it's a,
Okay, what's going on in that? I'm gonna just tell you, for time's sake. Whoever mounted that thing mounted upside
really
down.
know.
That's exactly the same as that. It's just mounted upside down. So, it's no different.
Oh, the box too. Should the box be a clue?
Yeah, I don't, anyway, I think this
The
is.
little black box?
All right,
Yeah.
let's just see. Okay. All right, you're a volunteer.
Push up.
Okay, what's going on here?
Wow.
So what kind of underbranch block does it look like? Right underbranch block. And is it regular?
Also, there is a cardiac block.
Okay, so what's the mechanism of the rhythm?
Is there some other block concurrent?
So what kind of block is it?
Third degree block.
Like a Byron's constant.
Yeah, QRS. So PVS.
I mean, peak here.
Remember the cardiologist, you just had cardiology, so what's the,
So we have a right bundle and we have a possibly a third degree block.
yeah, you got 30-degree heart block, because this is dead regular, so the P wave is never influencing the QRS. Those P waves are just marching through willy-nilly. I mean, that's P wave every, so this person complete heart block. And again, this would be somebody that on physical exam, you'd know they'd have variable heart down sound and be regular, so there's other things, but you'd be pretty sure they're in heart block.
And is there a way to determine where's the impulse, the ventricular impulse originating, maybe in the left ventricle versus in the right bundle?
No, I don't think you can say that. So, I mean, it could be in the AV junctional rhythm with the pre-existing bundle. This could be a ventricular escape rhythm, I don't think you would say. So.
Dr. Will, what is the difference between AV dissociation and like having a third degree? Because when you mention about beta, you have AV dissociation, but how is
I mean, the same thing exists.
It's just that rate, basically?
Right. Yeah, a lot of times you have high-grade AV block in which you have, it looks like this for a long time, and then every now and then, if the P wave happens to fall just at the right time, it'll depolarize the ventricle, so that would just still be high-grade AV block, but it wouldn't be totally complete heart block. So.
So how can the vent rate, sorry,
How can the
what
what?
is it the rate of the previous EKG?
I mean, I think that the,
46, yeah. So ventricular.
So what
I mean,
kind
that
of
means that-
mechanism
That means
of
like
having this, like, just the third degree AV block, or was there something else the person had?
or was there some what now?
Is there like a mechanism how he had right ventricular third degree AV block, or it was just?
No, but
regular?
I think the mechanism, the thing to remember is, I mean, here the guy's got or the woman's got a wide QRS, so you know they got pan conduction system disease. And so I'm not surprised they've got complete heart block also. I mean, it's usually people have a conduction system problem one place, they've got it in other places, so.
And how do you distinguish fascicular blocks, like, because I know
I
people
mean,
do that.
like this
left,
person
right.
probably has left, well, they don't have left ventricular block, but just by the axis, I mean, there's just the rules by the axis where there's left ventricular block, left posterior block, and there's just,
Can you teach us?
I can teach you, not right now. I mean, it's just something, we can go over that, but not on these.
Can
I think,
Can I interrupt for just one second,
Yeah.
because I have to go there with my daughter. Satasha and Brian, what was, in EMR, what was one of my huge pet peeves about the EMR in the hospital?
In the hospital?
Yeah, I mean, like copy forward, so you're saying things you really didn't do. Y'all, I've spent half a day in clinic, and I just want you, when you come to clinic, to document what you actually do. Please don't put down normal clinic, normal physical exam, because when I see you've done a rectal exam on every patient in clinic you saw that day, I'm really not gonna be very happy, because I know full well you didn't get anybody out of the wheelchair and do a rectal exam. Please look at when you pick brief physical exam or general physical exam, and then you go over there and you pick all normal. It says things you don't want it to say, okay? It really does, and it is fraud to put that down and sign it, that you did it or you didn't do it, or, like, something, I can't remember, the negative of something was, oh, without normal accommodation, pupils equal round without normal accommodation. Well, you're obviously not looking at the note that's been written if this is the end result. So please, it's important to get done with your notes in clinic, and we all want to be done with clinic when we leave the room, or we leave the clinic and go to our other part of our job, but clinic is just as important as the hospital, and I really would like to see notes that reflect what you did, okay? It just looks bad to put things down you didn't do, and to leave a note looking like, yeah, there's abnormalities on this note that you obviously didn't even look at the note you wrote, okay? So let's pay attention to that, I'd really appreciate it. It would also make our job a lot easier of reading your notes, because then you're not gonna get them all back to redo, and then we have to redo it again, and, we play back and forth note tag, so, because you will get them back from me, and I'm sure Dr. Florence.
Oh, you all know you get them back.
Yeah, so let's
Well,
just make
you don't.
everybody's life and job easier by looking at what you document in the first place, okay, guys? Thanks.
Thank you.
Thank you.
All right, this is the last one to tell.
Oh, sorry.